UA is a commonly ordered panel of tests on a sample of urine which can evaluate a wide variety of medical problems, including kidney failure, urinary tract infections, kidney and ureteral stones, and goo malignancies, acid-base disorders, abnormalities, the volume status ramped up analysis, and response to alkalinization therapy, which can be undertaken to improve excretion of certain drugs and toxins. Urinalysis, UA, normal results. pH 4.5 to 7.5. Protein, negative. Glucose, negative. Ketones, acetone, negative. Blood, hemoglobin, negative. Leukocytes, negative. Nitrites, negative. Bilirubin, negative. Urobilinogen, 1 milligram per deciliter. Negative is normal for almost all of these dipstick tests. It means the substance is not detected in the urine. Positive findings, e.g., protein plus, glucose plus, blood plus, usually indicate a pathological process that requires further investigation, like kidney damage, diabetes, or infection. The color of urine can be used as a rough guide of how well hydrated. There is definitely a strong relationship between urine color and hydration. It can potentially be influenced by a great number of other things such as medical conditions, medications, and even some foods. Normal variation, hydration. Light yellow/straw, well hydrated. Dark yellow/amber, dehydration/concentrated urine. Abnormal colors and causes. Color. Key causes/concerns. Red, most concerning. Usually indicates bleeding, hematuria, anywhere in the GU tract, kidneys to urethra. Orange, often due to hyperbilirubinemia, liver disease, or hemolysis. Also caused by the drug rifampin. Brown/black. Rare, often a severe/concentrated version of red or orange causes, e.g., old blood, myoglobin. Green, rare, Pseudomonas UTI or medications, e.g., methylene blue mixing with yellow urine. Purple, rare, associated with infected urinary catheters, purple urine bag syndrome. White, rare, caused by hypercalciuria or chyluria, lymphatic fluid, often from filariasis. Turbidity, cloudiness, can indicate a UTI, pyuria, or precipitated crystals. Nonspecific, do not diagnose a UTI based on cloudiness alone. Always correlate with dipstick and symptoms. The specific gravity is a measure of relative density. The ratio of the density of urine to the density of water vary from 1.003 up to 1.030, depending upon renal perfusion and volume status. In a euvolemic state with normal renal perfusion and healthy kidneys, specific gravity typically ranges around 1.010 isostenuric, meaning urine osmolality is roughly equal to serum. If the specific gravity is close to 1.001, that is urine more dilute than normal, it implies the patient has excessive hydration, a condition called diabetes insipidus, which can be caused by either deficiency or resistance to antidiuretic hormone, or ADN, in which the kidneys lose the ability to concentrate urine in the tubules. A specific gravity close to 1.035 largely implies either dehydration or SIADH. It can also be seen in the impaired perfusion, in CHF and cirrhosis and glycosuria, proteinuria, and recent administration of IV contrast. They all lead to high specific gravity as well. If a patient who has a specific gravity that seems fixed right around 1.010, no matter whether the patient is dehydrated or overhydrated, the specific gravity doesn't seem to vary very much. This person likely has advanced kidney failure, in which the kidneys lose their ability to regulate urine concentration. Urine pH. Distal tubular vessels exchange hydrogen for sodium of the glomerular filtrate, and the urine becomes acidic. UA pH clinical significance. Urine pH too low, acidic, less than 4.5. When urine pH is consistently low, very acidic, it means the kidneys are excreting a lot of acid, or there is a systemic issue causing high acid production. Common causes: metabolic/respiratory acidosis. The body is too acidic, so the kidneys try to compensate by dumping H into the urine. Starvation/diabetic ketoacidosis. DKA, the body burns fat, producing ketones, acids, that are excreted in the urine. Severe diarrhea, you lose bicarbonate, base, in the stool, leading to metabolic acidosis and acidic urine. High protein diet / cranberry juice, metabolism of protein produces acid. Phenylketonuria, PKU, a genetic disorder. 2. Urine pH too high, alkaline, greater than 7.5. When urine pH is consistently high, it means the kidneys are excreting too little acid or retaining too much acid or excreting too much base, often due to the blood being too alkaline. Common causes: metabolic / respiratory alkalosis. The body is too basic, so the kidneys conserve H, stop excreting acid, making urine less acidic, more alkaline. Urinary tract infection, UTI, specifically with urea-splitting bacteria like Proteus or Klebsiella. These bacteria break down urea into ammonia, which makes the urine alkaline. Renal tubular acidosis, RTA, type 1. This is a paradox. Even though the patient has acidic blood, the kidneys cannot acidify the urine. The pH stays high, greater than 5.5, despite systemic acidosis. Vegetarian diet. Plant-based diets produce less acid. Postprandial, after meals, the alkaline tide. As the stomach secretes acid for digestion, the blood becomes temporarily alkaline, and the kidneys clear this by making urine alkaline. Certain medications: acetazolamide, potassium citrate, sodium bicarbonate. Proteinuria means this glomerulus barrier function is damaged or overwhelmed. 1. Renal diseases. This is the most direct cause. Proteinuria is a hallmark of chronic kidney disease, CKD, and glomerulonephritis. The mechanism is related to damage to the glomerulus and loss of negative charge. 2. Diabetic nephropathy. This is the leading cause of end-stage renal disease in the U.S. The mechanism is related to hyperfiltration injury by high blood sugar. 3. Preeclampsia. Proteinuria after 20 weeks of pregnancy is a defining feature of preeclampsia, along with hypertension. The mechanism is related to endothelial damage to glomerulus, swelling of cells. 4. Multiple myeloma. The mechanism is related to overproduction of immunoglobulin proteins, light chains, Bence-Jones proteins. 5. Salt depletion, volume depletion / dehydration, causes a mild, usually reversible, form of proteinuria. The mechanism is related to orthostatic / postural proteinuria and concentration effect. 6. Blood loss. Severe hemorrhage causes proteinuria primarily through prerenal mechanisms. The mechanism is related to hypotension / shock leading to ischemia, acute tubular necrosis, ADN leading to loss of reabsorption ability. If the hemorrhage is massive and involves blood transfusion reactions or breakdown of RBCs, hemoglobin can directly appear in the urine. Glucosuria occurs when the blood glucose level is so high that it overwhelms the kidney's ability to reabsorb it, exceeding the renal threshold of 180 mg/dl, or when the transporters themselves are damaged. 1. Diabetes mellitus. This is the most common cause. The mechanism is related to hyperglycemia, due to lack of insulin, type 1, or insulin resistance, type 2. The amount of glucose filtered by the glomerulus exceeds the capacity of the renal tubules, SGLT2 transporters, to reabsorb it. 2. Cushing's syndrome. High cortisol levels lead to high blood sugar. The mechanism is related to insulin resistance. Cortisol stimulates gluconeogenesis and makes cells resistant to insulin. Steroid-induced diabetes leads to elevated blood glucose. 3. Pancreatic disorders, pancreatitis, cancer, cystic fibrosis, causing beta cell destruction. Lack of insulin leads to diabetes mellitus, called pancreogenic diabetes, and consequently, glucosuria. 4. Severe burns, myocardial infarctions, fractures, trauma. Severe burns, heart attack, major trauma trigger a massive release of stress hormones, cortisol, epinephrine, adrenaline, and growth hormone. These hormones all work to increase blood glucose. 5. Infections, severe / sepsis. The body's immune response disrupts glucose control. Inflammatory chemicals, TNF, IL-6, interfere with insulin signaling, causing insulin resistance. Like trauma, severe infection raises cortisol. Stress hyperglycemia, leading to glucosuria. 6. Liver disease such as cirrhosis, hepatitis. Impaired glycogen storage. Liver disease often leads to a condition of glucose intolerance. When glucose is unavailable or cannot be used, the body switches to burning fat, which produces ketones, acetoacetic acid, beta-hydroxybutyric acid, acetone, as a byproduct. Ketonuria always means the body is relying on fat because there isn't enough glucose available due to starvation, fasting, illness with poor intake, or usable in diabetes, no insulin. In a diabetic patient, ketonuria plus hyperglycemia equals DKA until proven otherwise. 1. Diabetes mellitus, DKA, is the most critical cause. Ketonuria in a diabetic patient is a medical emergency until proven otherwise. Without insulin, glucose cannot enter the cells. Starvation at the cellular level, even if blood sugar is high. The body breaks down fat stores for energy, producing massive amounts of ketones. 2. Alcoholism, alcoholic ketoacidosis, is a common syndrome in chronic alcoholics after a binge, especially if vomiting occurs. Alcoholics often have poor nutrition and empty liver glycogen stores. Alcohol metabolism alters the NAD/NADH ratio in the liver, shifting metabolism toward ketone production. Vomiting/dehydration worsens the state, causing the body to release stress hormones that promote fat breakdown. 3. Acute febrile state in children is common. Fever drastically increases the body's metabolic rate. Burning through glucose stores quickly. Sick children often refuse to eat with poor oral intake. The combination of high demand and low intake depletes glucose, forcing the body to burn fat, leading to starvation ketosis in the child. 4. Dehydration/vomiting/diarrhea. Fluid loss leads to metabolic shifts. Loss of nutrients. Stress response alkalosis/acidosis promote fat breakdown, producing ketones. 5. Starvation is the classic physiologic cause of ketosis. After 12 to 24 hours without food, the liver's glycogen stores are exhausted. The body switches to burning fatty acids for energy. Leukocytes and nitrites are two markers almost always interpreted together on a urinalysis dipstick. They are the primary indicators of a urinary tract infection, UTI, that leukocytes indicates the body's immune response, inflammation. Nitrites indicates the presence of bacteria, specifically those that convert nitrate. 1. Urine leukocytes detects an enzyme, esterase, found in white blood cells. Its presence indicates pyelonephritis or inflammation somewhere else in the urinary tract. Kidneys, ureters, bladder, urethra. Pyuria is WBCs shed into the urine as they die or migrate through the inflamed tissue. However, WBCs can also appear without bacteria. This is called sterile pyuria due to kidney stones, interstitial cystitis, viral infections, TB, fever/dehydration. Leukocytes plus nitrites suggests inflammation or a UTI caused by an organism that doesn't produce nitrites, like Enterococcus or Staphylococcus saprophyticus. Could also be kidney stones. Leukocytes plus, nitrites plus, highly indicative of a bacterial UTI. 2. Nitrites in urine detects the conversion of nitrate to nitrite. Its presence is related to bacteria. Bacteria reduces nitrates into nitrites. Not all bacteria can do this. Gram-positive bacteria, like Enterococcus or Staph, often do not reduce nitrate to nitrite. You can have a UTI but still have a negative nitrite test. Nitrites are very specific. If positive, it's likely bacteria, but not very sensitive. Many UTIs will be negative. Leukocytes are sensitive. Most UTIs will have them, but not specific. Other things cause inflammation. Therefore, the combination is the strongest indicator. If both are positive, the patient likely has a UTI. Bilirubin in urine detects conjugated, direct bilirubin. Unconjugated bilirubin is bound to albumin and cannot pass through the glomerulus. Its presence indicates liver disease or obstructive biliary disease. If the bile ducts are blocked by a gallstone, tumor, or stricture cholestasis, conjugated bilirubin cannot flow into the intestine. It backs up into the liver and spills into the bloodstream. If liver cells are damaged, hepatitis, cirrhosis, They cannot process bilirubin properly, and conjugated bilirubin leaks from the cells back into the blood. Conjugated bilirubin is water-soluble. It is small enough to be filtered by the kidneys and appears in the urine. The urine often looks dark brown or cola-colored, like dark beer or tea, due to the bilirubin. Bilirubin in urine causes hepatitis, either viral or alcoholic, cirrhosis, gallstones in the common bile duct, pancreatic cancer, compressing the bile duct. Urobilinogen in urine measures the amount of urobilinogen, a breakdown product of bilirubin, that has been reabsorbed from the gut and excreted by the kidneys. Normal, less than 1 milligram per deciliter, small amount is normal. Urobilinogen can be high or low, indicating different problems. For increased urobilinogen, if red blood cells are being destroyed too fast, hemolysis, the liver is overwhelmed with bilirubin. Due to overproduction, the liver sends it to the gut to process the excess. Bacteria create excess urobilinogen, more is reabsorbed, and the kidneys excrete the surplus. Causes of high urobilinogen: hemolytic anemia, massive bruising / hematoma resorption, early stage of hepatitis, decreased / absent urobilinogen. If the bile duct is completely blocked by a stone or tumor, bilirubin never reaches the intestine. Bacteria cannot create urobilinogen, causing urobilinogen in urine absent. Causes of low / absent urobilinogen: obstructive jaundice, gallstone, pancreatic tumor. Broad-spectrum antibiotics. These kill the gut bacteria responsible for converting bilirubin into urobilinogen. Severe liver failure. End-stage, the liver cannot excrete any bilirubin. In summary, bilirubin in urine always means something is wrong with the liver or bile ducts. It should never be there. Urobilinogen tells you the story. High urobilinogen, think hemolysis or early hepatitis. 0/low urobilinogen, think obstruction or antibiotics. Hematuria can be gross hematuria, which means visible to the naked eye, red, pink, or cola-colored. Or microscopic hematuria, invisible but detected on a dipstick or under a microscope. 3 categories: causes: prerenal, blood issue; renal, kidney issue; or postrenal, drainage issue. 1. Hemolytic anemia is a prerenal cause. Red blood cells are destroyed due to autoimmune reaction, transfusion reaction, or toxins that releasing free hemoglobin into the plasma. Hemoglobin is a small molecule that filters through the glomerulus into the urine. The dipstick will be positive for blood. If there are no intact RBCs under a microscope, this is called hemoglobinuria. 2. Urinary tract infection, UTI, is a postrenal or renal cause due to infection. Bacteria infect the bladder, cystitis, or kidneys, pyelonephritis, causing the lining of the urinary tract to become inflamed, friable, erosion, irritation, and bleed easily. 3. Benign prostatic hyperplasia, BPH, is a postrenal cause. Enlarged prostate compress veins on the surface of the prostate and bladder neck to become engorged and distended. When the patient urinates or strains, the pressure changes or physical force can rupture these veins, causing bleeding. Often presents as terminal hematuria, blood at the end of urination. 4. Radiation cystitis is damage from cancer treatment. Besides direct tissue damage to the DNA and blood vessels of the bladder lining. Over time, months to years later, fragile, abnormal blood vessels form in the bladder wall. These vessels bleed easily. Telangiectasia. Chronic inflammation making the bladder lining prone to ulceration and bleeding. 5. Malignancies due to tumor angiogenesis, tissue invasion, necrosis. The most common presenting sign of bladder cancer is painless hematuria. Renal cell carcinoma often causes painless gross hematuria. 6. Renal disease, glomerulonephritis, is a renal cause in diseases like IgA nephropathy or post-streptococcal glomerulonephritis. Glomerular damage render glomerulus lost filter function, causing RBC leakage. Dysmorphic RBCs by force can be seen, which confirms the bleeding is coming from the kidney, not the bladder. In summary, dipstick positive plus no RBCs under microscope. Think hemoglobinuria, hemolysis, or myoglobinuria, muscle breakdown. Painful hematuria usually indicates infection, UTI, or stones. Painless hematuria, Assume cancer, renal, or bladder, until proven otherwise. This is a red flag sign. RBC casts under the microscope. The bleeding is coming from the kidney, glomerulonephritis. 5 classic patterns of UA abnormalities. First, UTIs. The urine of the patient with a UTI is frequently cloudy or turbid. It can have any specific gravity. Protein may or may not be present. Leukocyte esterase is almost always positive, and nitrates may or may not be positive, partly depending upon which specific species of bacteria is causing the infection. RBCs may be present, and WBCs are almost always present, while CAS are usually not seen. Dehydration, or more generally decreased renal perfusion. The urine will be concentrated, so it will appear dark yellow and have a relatively high specific gravity. Protein may be positive on dipstick on account of the low urine output and secondary increased concentration. Leukocyte esterase, nitrites. RBCs and WBCs are all negative, and hyaline casts are common. With acute tubular necrosis, the color may be dark yellow or amber. The specific gravity is relatively low since the dysfunctional tubules lack their normal concentrating ability. Protein, leukocyte esterase. RBCs and WBCs all may or may not be present, and ATM is classically associated with so-called muddy brown casts. There are 2 categories of glomerular disease in the nephrotic syndrome. The urine can look foamy on account of proteins decreasing the urine surface tension. The presence of severe proteinuria also leads to a very high specific gravity. Leukocyte esterase, nitrites. RBCs and WBCs are all absent, and the urine may contain fatty casts. In nephritic syndrome, the urine can look red or brown, and specific gravity is relatively high. Protein may be mildly or moderately elevated. Leukocyte esterase may or may not be present. RBCs are almost always present, and dysmorphic morphology is strongly suggestive of this specific diagnosis as opposed to other etiologies of hematuria. WBCs may or may not be present, and the patient may have RBC casts on microscopy.